Moving on to how we treat pain. We're going to talk about this in several different sections. First, we're going to talk about treating nociceptive pain. We're going to go through a little bit about how to treat it overall, and then we'll get more into the details with acute versus chronic. And then we'll talk about treating neuropathic pain. The goals of therapy are listed here. I want you guys to know these just because they are important and they do underline what we're doing as far as treatment. You do not need to memorize them by any means. But what we want to try to do first is try to remove or cure the underlying disease. Next, we're going to try and decrease the patient's pain to a tolerable level. This is important because we can't always make a patient's pain zero. And it's good to have that discussion with patients beforehand as well. And we'll talk about that more here in a little bit. We also want to make sure that we're improving the patient's quality of life, maintaining function, and facilitating recovery. In many ways, when we help patients' pain get to a tolerable level, they're able to do things like participate in PT and live a more healthy, fulfilled life. We want to minimize the adverse effects associated with drug therapies as well, and then avoiding the overprescribing of opioids. Another thing is that many times acute pain can progress into chronic pain. So with acute pain, one of our goals is to avoid the patient becoming a chronic pain patient. Now, there are a lot of guidelines for acute pain. The two that I use the most, and I used the most in creating this, were the ACS quality of trauma and the VA's acute pain. We will talk about chronic pain as well, and you'll see that there are a lot of guidelines for this as well. We will specifically make some recommendations regarding low back pain because those guidelines are a little bit differently. But most of our recommendations do come from the ASIPP guidelines, the Veterans Department of Health, and the CDC guidelines for the treatment of opioids for chronic pain. The first thing you want to do whenever you want to treat somebody's pain is try to figure out what kind of pain you're treating. As I've already noted, we treat acute pain different than chronic pain. We treat nociceptive pain differently than neuropathic pain. So we want to make sure we have a good feel for what is going on with the patient. If you can find a source for a patient's pain, such as an acute pain, and mostly an acute pain, but sometimes chronic pain, and try to do some sort of intervention to help relieve that pain, that can help a patient's symptoms. So in acute pain, you might want to try to find the source or the insult. Now this can be anything from a patient with appendicitis and abdominal pain, getting an appendectomy, to splinting a leg or fixing a dislocated shoulder. In chronic pain, it gets a little bit harder because sometimes there's no underlying condition that can be found. Also, there are some disease states that are just associated with chronic pain, such as sickle cell disease, rheumatoid arthritis, and Crohn's disease. So those inflammatory disorders. Now, there are some structural diseases, such as vertebral disc disease, that we can do different types of lumbar procedures on, and bone-and-bone degenerative diseases that we can do procedures on. And then sometimes in neuropathic pain, we may be able to relieve a nerve compression that helps with the patient's symptoms as well. What I want you guys to know from this is the first thing you want to do is try to figure out, if able to, what the cause for the patient's pain is and take care of it. And knowing that once you do that, you might need less pain meds afterwards. Along with that, you also want to start out with some non-pharmacological therapy. Now, non-pharmacological therapy includes all the things we listed here and patient education, which we're going to talk about on the next slide. So, first off, you might want to start with, well, actually you can do all these at once, depending on the patient's specific wants, needs, and views towards different therapies. But starting with local care, you have ice, heat, rest, elevation, trying to position the patient, and splinting the diseased area. Another option is what's called TENS. Now, TENS is transcutaneous electric node stimulation. It's where we put electric nodes on patients' legs, arms, whatever, and provide electric stimulation to the area. This sometimes can help relieve a patient's pain. It's usually done by physical therapists. We've had a couple patients on my service that have really benefited from this. Another thing you can consider is complementary or integrative therapies. Acupuncture has been shown to be quite effective in clinical trials. Now, granted, there are some trials that have shown that acupuncture versus sham acupuncture, where you just stick some needles into somebody and I guess you don't know what you're doing, shows no difference. But patients do report improvement with acupuncture. Massages and chiropractic therapy have also been known to help improve patients' pain. Rehab therapy can include PT, OT, and therapeutic exercise, which is a type of physical therapy. And speaking of exercise, certain exercises, such as low impact exercises that involve stretching, swimming, walking, Tai Chi, yoga, and chair exercises, have been shown to be effective for patients in treating their pain. Psychologically speaking, there are a couple different types of therapies that can be used, including cognitive behavioral therapy, mindfulness-based stress reduction therapy, and acceptance and commitment therapy that have all been shown to help patients with their acute or chronic pain. In chronic pain specifically, there are these comprehensive pain rehabilitation programs that provide a multidisciplinary approach to patients' pain and try to provide comprehensive therapy. This would include clinicians, nurses, psychologists, physical therapy, occupational therapy, and even vocational counselors. These things are very few and far between, and in many cases, sadly, the cost of maintaining this has not been able to be completely covered. Another really important part of non-pharmacological therapy is patient education. This starts with setting the patient's expectations, making them understand that our goals here are to make their pain tolerable. We cannot remove all of their pain. So you're trying to get the patient's pain at a manageable level. One other thing we can try to do as far as non-pharmacological therapy and patient education is trying to treat sleep disturbances. CPTI is actually a free program through the VA that helps relieve patients' helps with patients' sleep disorders. And it's free and it's an app on your phone. If you do have to do pharmacotherapy, you do always want to try melatonin before benzodiazepines. That's what BZD stands for. And then also there's what's called neuroscience education, primarily used in chronic pain. This is the idea of giving patients a better psychological reasoning for their pain. Making sure that they understand their injuries have healed and they still have pain. Reducing the fear associated with pain. A lot of times patients have anxiety and false pretenses regarding their pain, thinking that they've done something wrong to themselves or that if they do things a certain way, their pain's going to get worse. So trying to reduce those fears. And then also there are some biopsychosocial mechanisms that are available through this therapy as well. The idea is that sometimes hurt doesn't harm, meaning that even though your body hurts when you do certain mechanisms, you're not harming your body. And that's something that you have to rewire your brain to in chronic pain. Because as I've mentioned many times, there might not be any structural problem behind a patient's pain. And unlike in acute pain where we're trying to prevent re-injury, in many cases in chronic pain, it's more just that the body has some kind of negative feedback loop. Along with non-pharmacological therapy, we do group a large amount of therapies under the title of non-opioid therapy. First, you have your non-opioid analgesics. These are agents that are specifically for relieving pain that are not opioids. This includes NSAIDs and acetaminophen. In many cases, including in the osteoarthritis guidelines, NSAIDs are considered first line, with acetaminophen being an alternative or given with NSAIDs. Also, you have symptom-driven adjuvant therapy, and for most of our cases, we'll call this adjunctive therapy. That can include anti-epileptics such as gabapentin and pregabalin, and then sometimes some of these other agents, but primarily gabapentin and pregabalin are used. Skeletal muscle relaxants such as cyclobenzaprine, methylcarbamol, and tizanidine. Serotonin norepinephrine reuptake inhibitors, also known as SNRIs, the primary one used being duloxetine. Tricyclic antidepressants with amitriptyline, desmoprine, and nortriptyline being used the most frequently. local anesthetics such as lidocaine, and local analgesics such as capsaicin, and then ketamine, which is an NMDA receptor antagonist that is only really used in ICU patients. And we'll talk about that more as we go through the lecture today. You also have an option for interventional therapies. The idea here is that you do some sort of intervention other than opioids to try to relieve a patient's pain. This can be something as simple as an office-based injection, such as getting steroids directly into a joint or an injured space. Pain pumps, where they place a catheter intrathecally and they use it to direct medications directly into the intrathecal space. These can either be implanted, so I had a patient recently who theirs was completely implanted and they had no control over, or these can be worn as like a pack. So there are some patients that may have packs with them as well. There's also these ideas of peripheral nerve blocks versus epidural. The biggest difference here, because they both use local anesthetics, is that peripheral nerve blocks really just focus on one part of the body. So this is often used in patients that have arms, hands, or leg surgery because it's just really focusing on that one part of the body. So for example here, this picture shows the brachial plexus. If you do give anesthetic into this area right here, you will have complete block. Versus if you're further here, you may just have a axillary block. The idea is to just block the area where the pain is the worst. Versus epidural and spinal anesthesia really does do a full region of the body in a much larger region of the body. So if you think about women who are pregnant, who get epidurals, this is what we're talking about, where they completely numb everything from the waist down.